Good afternoon, everyone. We'll just get ready to start the meeting. Are we ready to record? We are recording. Thank you. Good afternoon. I'd like to welcome members to this afternoon's in-person meeting of the Rutland Health and Wellbeing Board, and to Councillor Wilby, who's online, and to other members of the public who are listening via the Zoom board webcast. We have another busy agenda for today's meeting. So firstly, to practical matters. We're not expecting a test of the building's fire alarm this afternoon, so if the fire alarm does sound, could attendees please exit the building by the nearest exit, and the rallying point is at the rear of the car park. I'd like to remind members of the board to please raise their hand if they wish to speak, and to ensure that their microphone is switched on when addressing an item for the benefit of the webcast, and recording and muted when not. I'll refer to Jane from governance if I need to record a vote for any procedural matters. Thank you. So first, moving to apologies. Jane, have we received any apologies?
Yes, Chair, we have received apologies from Mark Powell, Dr. James Burden, Simon Barton, Inspector Lindsay Madeley Harland, that was Nee Booth, and then Louise Platt. Thank you.
Record of meeting, we need to confirm the minutes of the Health and Wellbeing Board meetings on the 11th of October 2022 and the special meeting on the 13th of December. I'll propose the minutes for the 11th of October. Can I have a seconder, please? Thank you, Deb. And all those in favour, please raise your hands.
Thank you, Chair, that's unanimous.
Thank you. And for the minutes for the 13th, I'll propose them. Do I have a seconder? Dr. Underwood, and all those in favour. Thank you.
Thank you.
So that there were no actions arising from the special meeting on the 13th of December, but we do have 4 actions from the meeting held on the 11th of October. The health inequalities in Rutland, Mitch is here today to deliver that part, so that's later on in the agenda. Action 2 was for myself, Deborah, Catherine and John to meet to identify an agreed format for the update reports. We've done that and they're enclosed. Item 3 was Catherine to collate falls data and distribute a briefing to board members for their information. I think that is still in progress. Am I right, Catherine?
We still need to unpack the data around the falls and hip fractures and the 14-day stays in hospital, because we think the 2 measures might be conflicting with each other. So we need further clarification on that.
Thank you very much. So we'll carry that forward to our next meeting. And then item 4 was Councillor Harvey, Dr. Burden and Mike Sandys to arrange a joint communication regarding the winter vaccinations. I think we covered that off, if my brain reminds me.
Yeah, thanks, Chair. I can remember doing lots on communication and vaccine. I can't really recall if we did a joint one between the 3 of us.
I'm not. I think we'll check for the minutes, because I'm not sure, and it seemed an awfully long time ago, last October.
It's one of those ones. Yeah, if we haven't, it's a bit late.
Yes, thank you. Yeah. So item 4 is declarations of interest. Do we have any interest to be declared this afternoon? No, thank you. So now to petitions, deputations and questions. Jane, have we received any petitions, deputations or questions?
Yes, Chair, we have received 2 questions with notice, one from Mrs. Jennifer Fenelon and one from Mr. Miles Williamson Noble. The questions have been added to the Council's website and circulated to committee members in advance of this meeting. Mr. Williamson Noble is unable to attend today's meeting, so he has asked Mrs. Fenelon as his representative to present his question to the board. As per Procedure Rule 93, the total time allowed for each question submitted with notice, including the response, will be 5 minutes, and Mrs. Fenelon may ask 1 supplementary question for each question for the purpose of clarifying the response. May I please remind everyone that every question must be read exactly as submitted. No changes or amendments to the submitted text are allowed. No discussion shall be permitted, nor a resolution moved with reference to any question or reply to a question. I shall now ask Mrs. Fenelon to approach the table and read out her questions.
Good afternoon, Ms. Fenelon. Please read out the first question.
I'm sorry, Mrs. Fenelon, you need to use the microphone.
Thank you.
Thank you.
First question. The Leicestershire and Rutland LLR 5-year forward plan is due to be finalised by the end of June 2023 and will govern how capital and revenue is spent over the next 5 years across LLR. It will be derived from, inter alia, place needs assessment, JSNAs, place plans, and the Integrated Care Board ICB strategy. After over 2 years preparation, has the Rutland Health and Wellbeing Board yet completed translation of its place strategy into firm capital and revenue proposals to go out for consultation in April? We are confident that your place plan implementation proposals, when known, will be supported by Rutland people.
Thank you, Ms. Fenelon. I think that Ms. Mitchell, oh, sorry. Is that Sarah or? Sarah. Thank you.
So the LLR joint 5-year plan, which I'll talk about a bit later actually in the ICB update, will set out how healthcare will be delivered across LLR over the next 5 years, and needs to take into account, as you've just said, the JSNAs and the health and wellbeing strategies. The guidance for the joint plan requires the health and wellbeing boards to consider and comment on that plan. And as a health and wellbeing board, you will have the opportunity to comment on that plan. And at the moment, we're working on details around the exact timings of that, given the fact that we've got local elections and the timescales are quite tight for the end of June. So we're just working on timelines in terms of when that will come through to the health and wellbeing boards. And it's important that that you consider that plan, not only because it's a legal requirement that you do, but also, as we've just heard in the question, that you make sure that they align to the local plan that you've set out.
Thank you. Mrs. Fenelon, do you have a?
Yes, I think my supplementary question is that there is still concern that the JSNA is not finished yet. It still has considerable work to be done. And the place strategy is still a lot of aspirations, but it is thin on firm proposals. And those need to be taken into account in the 5-year plan.
I don't know whether Mike wants to say anything about the JSNAs, but.
Yeah, I mean, only also look across the room. The JSNA, I'm going to say to some extent, the JSNA is like the fourth bridge. If people are expecting there to be a kind of finite deadline and then it's done, we as board will know, said a long time ago, that it'd be an evolving and revolving process whereby we publish the chapters as we go. And obviously there's a few chapters on the agenda today. That doesn't mean to my mind that there isn't sufficient detail in the JSNA for us to move forward with our translation. And the other bit for me, Sarah, is the 5-year plan and the ICS strategy isn't just the 3 place-based ones bolted together, that the ICS needs to pay due regards to the JSNA and the strategy and then take its own system level investment decisions. Then we need to work out what is ours at place. So
yeah, that's correct.
Yeah.
And the other thing about the 5-year plan, it has to be updated every year. So it's not a set plan in terms of, for the next 5 years. It will evolve because it needs to be updated every year in line with legislation.
Thank you. I'm sure we will debate further when we come to that bit on the ICB update, and also we have got the JSNA timeline, I know is later on the agenda as well, so we might be able to give some clarification later on. So Mrs. Fenelon, can we go to your second question, please? You have a total of 5 minutes to read. Thank you.
This is on behalf of Air Commodore Miles Williamson Noble. The report on the Adult Social Care Discharge Fund at agenda item number 11 shows that Rutland will be receiving £155,271 via the ICB and £113,100 directly as a local authority from the 700 million allocated nationally to address the issue of patients fit for discharge remaining in hospital. What proposals have been submitted for use of this money and what outcomes are expected?
Thank you. The Better Care Fund, Adult Social Care Discharge Fund, the aim of which is to support timely and safe discharge from hospital by reducing the number of people delayed in hospital awaiting social care. Rutland received 130,100 as the local authority grant and a further 155,271 as the ICB contribution. A report on how Rutland as a place in LLR as system of responded is covered in item 11. There has been a proactive response by working with partners to identify schemes to promote timely discharges from hospital. The funding has enabled the commissioning of 4 beds at Rutland Care Village for the purpose of re-enablement. This is helping to facilitate discharges from hospitals, given the pressure in the system with the shortage of community rehabilitation beds at community hospital sites. The discharge funding for step down, the 200 million, that fund's designed to increase capacity in post-discharge care and support improved discharge performance, patient safety, experience and outcomes. Through the use of this fund, ICBs are expected to deliver reductions in the number of patients who remain in hospital but do not need to be there, and improvements in patient flow. To help waiting times in EDs and handover delay, the ICBs have complete discretion in how the funding should be utilised. Direction from NHS England is that ICBs should commence the actions required to deliver this additional capacity immediately. Rutland County Council will be working with NHS colleagues to plan how to utilise this funding through the commissioning of step-down beds. The Rutland County Council discharge team use eTrack to track the patient journey through Peterborough City Hospital, and is in the process of registering with Nerve Centre, the equivalent for University Hospitals Leicester. This assists with tracking patients through hospital and preparing for discharge planning. RCC receives daily situation reports, SITREPs, from PCH and UHL, and there is a good working relationship with Kettering General Hospital. So in a data context, the following data highlights the number of and status of Rutland residents in Peterborough and UHL. You'd previously stated some numbers with people waiting on the 16th of January. So of the delays in Peterborough on that day, there were 5 Rutland residents that were classed as delayed. However, 3 of those delays were down to health issues. 2 were waiting for us and would have been classed as a Rutland County Council. Of those, 1 patient was waiting for a further 3 days, although 48 hours of that was for specialist transport, so was out of our hands. And the other delay was actually for less than 24 hours. And because we have daily SITREPs, we can say that as of this morning, we had 3 delays in Peterborough. 1 of them was down to health. 1 was awaiting care home and is actually self-funding, so is classed as neither health nor RCC. And then the other is waiting for home care to start, and so is down to us. In UHL, we have had no delays on both of those dates. So we are very proactive, and it's really a good story from our officers. They do fantastic work to prioritise and to keep track of our patients through the hospital to ensure that our delays are at a minimum. So that was the long answer. Do you have a supplementary you'd like to come back on?
Well, I need to stress there is no criticism of your staff. The rationale behind the question was that, and it's a question that's being asked across the country, was is discharging people into care homes the automatic answer to getting them out of hospital? And we wondered how much evaluation had been done, mainly to tie it in with the long-term plan that we just talked about, to say, is this the right thing? Should virtual beds be used? There are a lot of other methodologies, and we we didn't know what rationale had been applied to this
Yeah.
solution.
No problem. I'll just ask Mr. Morley as well to come back on that.
Hi, Jennifer.
Hi.
Yeah, our default always is to get people into their own homes. We use our care homes as a last resort, or perhaps sometimes if we need to get people out quickly, but we will staff our own reablement people around those residents, citizens, to get them out into their own homes. And I think it's worth saying that over the last 3 or 4 years, we have had very, very good results in Rutland. But that is down to how we work together, both local authority and health colleagues, and indeed the private sector. And I think that that's important that we reiterate that, and indeed it gives us foundations to build upon into the future.
Thank you, Mr. Morley. Thank you, Mrs. Fenelon. A written response will be sent to you and Mr. Williamson Noble, and a copy published with the minutes. Thank you very much. So next we go on to item 6, which is, oh, sorry, no, I've done something wrong. Hold on. Oh, yes, sorry, Mrs. Fenelon. Yes, I do need to remind you. Thank you. Now we'll move on to item 6, and which is question with notice from members. Do we have any questions?
None received, Chair.
Thank you. And item 7 is notice of motion from members. Do we have any?
None received, Chair.
Thank you. And we now go on to agenda item 8, which is in our packs, our huge packs at page 21, which is the joint strategic needs assessment updates and timelines, with 3 parts to agenda item 8. The first is an update from Adrian Allen. The second is a report from Mitch Harper about the health inequalities in end of life chapters. And the third is a report from Hannah Blackidge about the oral health needs assessment. Are you picking that up, Mitch? Or is Hannah's on? Oh, yes, thank you. And so, Mike, would you like to introduce these items, or are you happy for the officers to proceed?
I was only going to say what you were, so it was quite timely in the light of the question that this presents a couple of things: updated chapters on oral health and health inequalities. The first Adrian will set out the plan for the forthcoming chapters.
Thank you very much. Over to you, Adrian.
Thanks, Chair. Firstly, the plan for the JSNO chapters came to this board in October of 2022. There's not been a huge amount of change since then, but what I wanted to do was update you on what is complete, what we're working on currently, and where we might want to change the order slightly of what the rest of the plan as it's set out. So as you'll see, the oral health needs assessment is on the agenda for this meeting. That's been complete, pending agreement here. The pharmaceutical needs assessment has also been complete. The health inequalities and the end of life JSNO chapters again have been to this board before, but have come back here for formal sign-off. The 2 JSNO chapters that are currently being worked on are preparing for population growth and substance misuse. The substance misuse chapter was not in the list at this stage, but it was on the Leicestershire list, and because it's a combined integrated service, it made sense to do the Rutland one at the same time. So that has been pulled forward, but at no detriment to anything else on the list. So those 2 chapters are being worked on currently. Those are likely to come back to Health and Wellbeing Board in the spring of this year. The rest of the timetable now is as set out in October. So the next chapters on the timetable are learning disabilities, dementia, mental health, which is currently being scoped as a potential next JSNA chapter for 2023. Mitch is working on a refresh of the Rutland Military and Veteran Health Needs Assessment, working with Ian and others. That really is, it's not necessarily a refresh of the JSNA chapter, because there is a LLR JSNA chapter being developed currently. This is a piece of work specifically to Rutland, which will support the swap over of the forces in the summer, those battalions coming back from Cyprus. So it will feed into the JSNA, but it's a specific HNA chapter that Mitch is working on currently. We've got Best Start for Life, Staying Healthy and Independent, Healthy Aging, Equitable Access to Services, and COVID Recovery. The COVID Recovery one is the last on the list, just because at the moment it doesn't have a natural fit within the rest of the JSNA chapters. The ones that I've just talked about, Best Start of Life is in phase 2 of 23-24, so we're likely to see that towards quarter 3, quarter 4 of this year. Staying Healthy and Independent, again, is phase 2 for 2024, so likely to be between January and March of next year. And Healthy Aging is in phase 3, which is 24-25. So there is a clear plan set out there. Obviously we're moving through the plan as it is currently. The question for the Health and Wellbeing Board is really about what the priority is for the next chapter. So as I said in the plan, the next chapter that's being scoped is mental health. There has been a request from IDG to look at the dementia chapter, and we've got the learning disabilities chapter, which is also being scoped at the same time. Dementia chapter, I think, is timely to potentially be put next. The diagnosis rate for dementia for Rutland is quite a bit off at the moment. There's no real data surrounding that, so I think, you know, as I said, IDG are requesting that. I think it will support the work that they're doing, and certainly will give us some answers behind the data as to what the issues are around dementia diagnosis, with some clear outcomes for IDG to potentially pick up to move that work forward. What we would potentially do then is swap dementia and learning disabilities. So dementia would then effectively become the next chapter of the JSNA, and learning disabilities, and then mental health would then follow afterwards. Obviously, understanding that dementia and mental health do have some cross-cutting themes, so there may be some opportunity to join those up as they work through. That's the chapter. I've got a document that I'm reading from, which I can share with members afterwards. The request for the Health and Wellbeing Board is there an appetite to move the dementia chapter to next in line, and slip the learning disabilities chapter back to the next one.
Thank you. I will point out to the board that as part of the NHS year plan, dementia figures specifically are on there, and dementia rates, which is why I'm thinking IDG have probably asked for it to be pulled forward. However, I would, it's very tricky because both learning difficulties and dementia within the health arena have delays. And so I would actually like to, I'll bring in others, and I think Deb will, but what I would like to do is bring in our children's director for her thoughts around the LD arena, and whether what she feels, whether there would be any detriment for delaying the JSNA on learning difficulties, or if putting dementia before it. I didn't know if she had any thoughts. Sorry, I've put her right on the spot there.
I think if we're talking about learning disabilities,
Yeah.
as opposed to difficulties, and I think that I just want to be clear about that. So I don't think there'd be so much detriment in relation to disabilities. If we're talking learning disabilities, I do think though, when we're thinking about children with learning difficulties and SEND, that's where there's more benefit for us to do that sooner rather than later in relation to JSNA, because there is a difference, basically.
Can we clarify that difference? And I think it's worth noting, because the priorities for health in their plan next year is around diagnosed difficulties, which is, and we are aware there's currently over a year wait for some neurodevelopment pathways. So So it's kind of a chicken and egg on the weight with health, but obviously a year or over a year, because by the time they get to the neurodiverse weight, they've already probably waited for speech and language. So that's a long time in a child's life and makes a radical difference, notwithstanding the dementia thing. So I think if we could have some clarity from Adrian, whether it is learning difficulties or learning disabilities, that might raise our thinking, and then I'll Deb to come in. Thank you.
So my understanding is that it is learning disabilities rather than learning difficulties. I can't identify learning difficulties on the list, so that's what we need to go back and look at, unless it's coming under the Best Start for Life chapter, but it doesn't fit well there. So I think I need to go back and talk to colleagues about where that potentially is going to sit.
I think that will be a helpful conversation for us to take away, Adrian. Learning difficulties and the crossover into the SEND agenda doesn't fit neatly in the Best Start for Life. It's much bigger than that for a start. And if it's not on the list at all, I think we do have I think it's a conversation that we need to have kind of outside of this meeting. We'll take it as a follow-up action. Couple of reasons. We do know, for example, speech and language therapy waiting times are huge, and they're really significant for children. 6 months in an adult's life is quite a long time, but it's an adult's life for 6 months. 6 months in a 1-year-old's life is huge, and I think there's them sort of issues that we need to get to grips with. And just as a reminder, we will be having an SEND joint inspection in the summer term between Easter and the end of the school summer term. I say will, highly likely. I haven't got inside knowledge, but that's something that we might want to just think about.
Yeah, absolutely. Just to clarify, this is learning disabilities across the life course.
Yes, of course, yeah. But I know specifically we do have massive issues, and COVID have made those issues worse on the waiting periods. And as Dawn has said, 18 months in a child's life makes such a huge difference to their progression through school and things, and has such an influence around their life. I'll let Deb come in, and then I think Janet had her hand up as well.
Thank you, Chair. So just to make it clear, the IDG did not ask for learning disabilities to be put back. We asked for dementia to be brought forward, but absolutely acknowledge workforce and time to do the work. So we didn't make a judgment or indeed have a discussion specifically on putting learning disabilities back. The reason that we wanted dementia sort of brought forward is we need information and guidance about the right sort of work to deal with what we know is an issue in Rutland. We know we've got an elderly population, and we know that issue is growing. So, I mean, in an ideal world, we'd do them both together. I'm presuming that that's not possible because of resource, but that was the reason that we asked for dementia to be brought forward. We can do some work on dementia without this, and we will do what we can, but it would be enormously helpful to have this piece of work brought forward to inform the work that we need to do to make the biggest impact. I mean, obviously there is a lot of work going on in learning disabilities and mental health, and in fact we've been quite sort of proud of the work that's going on locally within Rutland on that, but I absolutely acknowledge the points raised around putting back that piece of work.
Thank you. I think Dr. Underwood and then Mike coming in.
Yeah, it's just to sort of let everybody know that Healthwatch Rutland has been working with Healthwatch Leicester and Leicestershire, and we've been running a survey, focus groups and interviews of people's lived experiences with dementia. There is a report that should be going to the, I think it's the people, Deb might be able to correct me, people that are preparing the dementia, joint dementia strategy imminently. It's in its draft form. I just thought I'd read some of the statistics out that I've actually got, because they're quite earth-shattering for Rutland. Okay, statistically, it's estimated, if I can find it, there should be 707.7 diagnosed patients in Rutland diagnosed with dementia. In actual fact, we have 337 people that are diagnosed. So this is a 48% diagnosis rate. This was in September of 2022. The desire in England, the ambition in England is to have a 66.7% dementia diagnostic rate. So we are falling well behind. We are actually behind Leicester and Leicestershire on that as well. Statistically, there should be quite a few people with young onset dementia as well, and we haven't been able to contact any in Rutland. We also only managed to get 15 responses to our survey from people who are caring for people with dementia and 2 with dementia. And we spoke to a number of people at focus groups, etc. So our sample is quite small. That said, I've been drawing out the differences. We haven't yet decided whether what I've drafted as a sort of a Rutland report should go as an appendix to the Leicestershire and Rutland report, or should be a standalone report. But there's quite a lot of information about why people are not coming forward for diagnosis, what the carers' support needs are, and the barriers to accessing that support. So it's just to sort of update everybody.
Thank you. I think we'll all look forward to receiving that report. Mike, did you want to come?
Yeah, thank you, Chair. So not about the dementia or learning disabilities chapters, just looking at COVID recovery, the last on that list that you read out. I'm beginning to wonder, it probably felt like a really good idea at the time, but I'm beginning to wonder what's going to go in it by the time it's published. Because some of the COVID stuff will have gone. Some of the things around economic bounce back will have cropped up, you know, in plans. But then I was thinking, actually, there is a bit of work, which I don't know if it's a JSNA chapter, actually belongs to work that the ICS is doing, which is looking at kind of which groups have been disproportionately affected by COVID, and that's which is now reflected in the backlog. The joint up looking at Janet is, I wonder if that's one of the reasons, given the timing of September 2022 around Rutland's figures, is because that's people who've not been able to seek a diagnosis from a GP because GPs have been under pressure. So towards the back end of that thing, I wonder if we could just kind of, it might be a job done in rejiggling what we do with the second bit. The other point for me was healthy aging. And again, just by the by, thinking about the Levelling Up Fund bid for Rutland Memorial Hospital last week and the clinical trials. And I know that's about sort of getting more representation of older people into clinical trials, which is why it's good news for Rutland. But it would be nice if that chapter landed at the same kind of time we were kicking something off, because I'd love the Levelling Up Fund bid to be the start of something around healthy aging within Rutland in a way that we've not done before. So a couple of points there.
Yeah, no, that sounds good. I would also, just because I can, sneak in, I'll declare an interest, but on the COVID recovery, it is worth us looking at long COVID, and because by the time we come around to that, quite of those long COVIDs may well have diagnosis of ME, and ME services do need some work with the NICE guidelines. So there is a crossover there. Obviously, I would declare my interest. Thank you.
Yeah, just to come back on that, I think that's potentially why it's slipping back in the timeline, because it's not really clear yet what is needed. The other JSNA chapters will pick up COVID recovery naturally as part of the work that they're doing. So what will actually be left at the end is not identified yet. It's likely to be data rather than a full JSNA chapter. I'm just clarifying now. I think the SEND agenda is being picked up under the mental health JSNA, because the child mental health element's already been progressed. So I think it's being done under that.
Perfect, thank you.
Any further questions? We're already out of time. See, I promised I said I'd be on time today. It's already slipped. Do we have any further questions for Adrian? Adrian, when do you need the decision on the, is that a decision we could maybe look at outside and then get some more clarity over for us around what the learning disabilities does? And then can we come back at the March meeting? Would that be, or do we need a bit of a decision before? When do we need a decision?
I think we probably need the decision before the next meeting. I mean, in an ideal world, we would run all three concurrently together, but it is capacity. But I can take that away and we can look at that to see if there is an opportunity for cross-cutting things to be done together. So if we could have a conversation outside of the meeting.
Okay, is everyone else happy with that? And that we probably, I'm looking to Jane to say, I'll need to move in a slight amendment on that then, won't I? So that we can delegate, do we think? Or because if we're making a decision or we're noting it.
Yes, Chair, if you're happy to delegate to the decision to you or to an officer, that is up to the board to decide.
Okay, thank you. We'll come back to that then when we've done the rest of it so that we take it all together. So we'll come back to that. So next, I think we've got the health inequalities and the end of life chapter.
Yeah, thanks, Chair. So just to recap from the last meeting, well, the October Health and Wellbeing Board, I did go through the health inequalities needs assessment, and a colleague of mine went through the end of life one as well. So I'm not going to go through that in masses of detail, but just to pick up on some of the discussion which was raised and minuted in the October meeting. For the health inequalities needs assessments, we did look at the access to primary care around drive time and public transport and incorporated Melton surgeries into that analysis as well. So that is part of the needs assessment now as well. The data that was presented in terms of time taken to drive, time taken for public transport didn't actually change with Melton included, but it was important to factor in as it was raised. And as we know, residents of Rutland do attend those surgeries. So that has been incorporated in. The other aspects in relation to the development session that has now been booked in. So that is due to be a week today on 31st of January. So that's the Health and Wellbeing Board members. Hopefully you've all had an invitation to that. And we've also got some wider colleagues who have got links into that piece of work as well. So they're the main changes to the health inequalities one. The end of life one, like I say, I didn't present that one, but there wasn't too much of a discussion in terms of changes needed for that assessment. But we wanted to bring it to January's meeting for two reasons. One, to approve hopefully both of those needs assessments for publication. And the second part of that is agreeing some governance to take forward them work streams aligned to the joint health and wellbeing strategy. So what we proposed in there is for the health inequalities one, health inequalities work stream and priority 7.2, I think it is within the strategy, to be part of the Staying Healthy partnership, which just to reference is on the agenda later. So it's kind of chicken and egg on that one. And then the other aspect, the end of life, it was proposed whether that will be taken forward through IDG and the senior responsible officers for that respective work stream. So two aspects to those recommendations, but I'll pause in case there's any questions.
Thank you. Do we have any questions from the board? No, Dr. Underwood.
Yeah, I have just a slight concern, if you forgive me for raising it now. It's on the carer section on page 43 of the JSNA or 67 in the reports pack. What I'm hearing, and I've been hearing in dribs and drabs for quite some time, years actually, is that there's a reluctance of some people, particularly men, to actually register as carers. There's a fear, there's lots of different fears, I think. There's one sort of, it's pride. Another is that they're going to be left with all of the care which they don't feel that they're capable of managing. There's a fear of actually letting go and letting somebody else take it. There's all sorts of things in there, and I don't think that is particularly acknowledged in this report. I think there's a lot of people that are caring but are not actually being registered as carers. Is there anything that can be done about that?
The refreshed LLR carer strategy was launched last week, had its official launch last week. Those groups are picked up on that, and it is one of the recommendations, and it's one of the priorities in that new strategy. So we can ensure that the carer strategy is attached and that we send you copies, because that is picked up in there. Thank you, Mitch.
Just a slight addition to that on carers as well. The census data on carers is starting to come through, and some of that we can take down to real small geography across Rutland. So we can see where that care is being provided, unpaid care that is. So allow us to prioritise different areas of Rutland a lot more. And the session next week, we can delve into some of that detail where we're setting those priorities to really look at what we can do around different population groups and geographical areas of Rutland.
Thank you, Mike.
Yeah, thanks. And thanks, Mitch. I mean, I know we've been asked to approve the governance route, which I haven't got any problem with. I think staying healthy partnerships ideally placed. It's kind of self-evident, but I just want to sort of clarify. I'm assuming then that Health and Wellbeing Board would receive a report from Staying Healthy Partnership on progress towards the recommendations within, what, 6 months, 12 months? I don't want to just say nod through governance and not sort of think about what we're doing afterwards.
Yeah, absolutely. We did put in about having a 6-month kind of review of the whole Staying Healthy Partnership, which would incorporate the health inequalities work stream. But because health inequalities is part of the strategy anyway, there'll be the typical reporting mechanisms which will feed into around that priority 7.2. So that will still continue, and that will incorporate some of this work from the needs assessment and Staying Healthy Partnership as well.
Thank you. Just one other question from me. Obviously, in the end of life care, there's obviously pages 158 and 159 of the pack. The recommendations 8.1 to 8.5, they're really in depth. I suppose it's just can we cross-reference those maybe with the section on our joint health strategy, so that we link up? And again, as Mike said, it's just I wouldn't want to lose that good work, and so that we can then see that it is kind of being looked at, or we can follow those recommendations. That would be great. Thank you. Or come back with if someone else is taking kind of ownership of it. It's just that how we can ensure that the recommendations are picked up. But other than that, thank you, Mitch. They're both very, very good chapters. Thank you. Does that, no other further questions from anyone? Right, I'll draw the discussion to a close. So I'd like to confirm the following. I've lost my notes already. Let's change the wording. So we need to, I've got that one, but we need to do the second bit, didn't we? We were changing. I wrote on it. So we're changing the bit on the first thing, the overview of the decision on whether we're bringing the dementia forward or learning disabilities. We're going to take over. Now, shall we, as a board, are we happy to delegate that to myself, Mike and John Morley? Would that be, as a board, happy to delegate that decision through? And then what we can do is have a discussion outside with all parties on which we think would get best value. And it's unfortunate we can't run them both together because they are both so important, but I think we just need to have a real in-depth discussion about where we would go. So if the board are happy to delegate that, we'll make that as an amendment, Jane, if you can think of the wording for that. And then sorry, Deb.
Can I just make clear to all that should we decide not to bring forward the dementia JSNA chapter, we will still continue to do work on dementia. We won't just wait.
No, of course not. Sorry. Yes, we'll make that clear. This is for those watching, the JSNA is data underpinning. We already have the data there. It's just formulating work around that. So the data is already there. We obviously have it as a priority through health next year anyway, but it is just of which we'd get best value moving forward for our strategic, around our strategic look. So we are delegating that. We're approving the health inequality needs assessment and the proposed governance approach. We're approving the end of life needs assessment and proposed governance approach. And we're also going to publish the chapters on our website. So I'll propose, if I can have a seconder, Mr. Morley, and then if everyone else is in agreement, a show of hands. Thank you. Thank you very much.
Thank you, Chair.
Thank you for that, and thank you very much, Mitch, for all the hard work of the team and Adrian. So now we're on to number 9, which is the LLR integrated care system update.
Sorry, Chair.
Oh, sorry.
We've missed the oral health needs
assessment.
See, definitely don't want to miss that one. That's the really important one. Report number 18, 2023. From Hannah Blackledge, who I think if we can bring through.
You there, Hannah?
Hello.
Hi, Hannah, are you there?
Sorry,
Can you hear us?
sorry. Yes, that's me. That's the first time I'm joining in. I hope I don't lose the. I had some worrying signs about my internet not being up to scratch, but hopefully it will work. Thank you very much. I will try in about 10 minutes to summarize the findings of the chapter and direct you to, there is probably, because there's a lot of statistical information here, there is a lot of summary also in the document submitted and in the chapter attached. We basically, through our report, we start with the highlighting the relevant sort of demographic findings which came through the census and various other sources. And the known fact of ever-growing older population in Rutland and children, and with the reduction to children and young adults in the last 10 years and also going forward. The role of deprivation is highlighted in the report, although this is of a specific rural type, so it's a lot of questions of access to service, particularly with dental services, although probably the current service issue with NHS dentistry at the moment are probably of more impact than the actual physical access, but that's shown in detail in the report as well. We also are outlining all the relevant information about the higher risk groups for poor dental health in Rutland. In terms of the health needs, the children's health needs is assessed through looking in detail at the 2 surveys done across the country for the 3-year-old and the 5-year-olds. This was done actually now and about a couple of years ago, but these are the latest. Current year, in the current year, the year 6 or 11-year-olds will be assessed as well. Looking at the sort of statistics from these 2 surveys, it seems that both these younger groups seem to have oral health, which is an average similar or better to the national findings. And the only small outlier that we found among the 3-year-olds was a slightly higher level of decay of incisor teeth, which might be an indication feeding problems, like sweet drinks, basically. But saying that, the whole survey for this group is based on a very small sample for Rutland. So like with a lot of survey findings, has to be some caution, but there may be some indication. The similar thing wasn't found in Leicestershire. So overall, not a bad picture of health, saying that this is a picture from about a couple of years ago. So the current problems with services are obviously not yet, might not have yet the impact on oral health. In terms of adults, nationally, there has been some concerns over rising rates of oral cancer. And that's been going on for at least 15 years now. Although the rises in Rutland has a relatively small number of cases per year, so these trends are not significant, although they seem to be going with the general national picture. And mortality figures for oral cancer for adults are generally for Rutland not published because the numbers are small. Moving on to so this is briefly the health need as we can fathom it from the published data. Obviously the big issue is currently access to NHS dentistry. And this has been the commissioning aspect of it has been presented to the scrutiny committee last year. And there have been major concerns nationally and within the region with staff shortages and pressures on service, staff retention, and basically poor access to NHS dentistry. We in the autumn last year, we surveyed all the dental practices which not just the Rutland practices, but all those who are accessible to Rutland population. It's basically through the Find a Dentist, NHS Find a Dentist service, the closest 50 practices. And of those 50, there were basically none who were willing to accept any new adult NHS patients. Only 10% would accept children, and probably a third accepted only emergency referrals. We've also looked at things like access by public transport, walking distances, and driving times to practices within Rutland and cross-border. Another measure that sheds some light on access to NHS dental service is to look at the proportion of population within age groups which have been seen by a dentist in the last year for children or 2 years for adults. And although these figures are going to be skewed by the sort of lack of services, reduced services during the pandemic, there is a picture that emerges is comparatively Rutland's pickup after the pandemic break was a little bit slower than elsewhere. And although rates among children are picking up well, for adults, they are a little bit worse. Particularly of interest is perhaps the working age men in particular, the group who do not seem to be accessing the services as well as women. For children, the rates are generally a little bit better. It's again important to stress that a lot of this information is particularly for where the comparative sort of national level is now probably about a year, at least a year old. And where any findings are based on small numbers, they have to be treated with caution. We also, from probably from other things, the patient satisfaction rates are falling quite significantly, although the latest published date for that is 2021. So now 2 years ago. The report summarizes oral health improvement measures and looks at some indicators with for those as well. We've seen, for example, lower than expected fluoride varnish rates for Rutland children. There is, we highlight that there is currently no oral health promotion service within Rutland beyond advice. And that there is an oral health promotional partnership boards, which is cross LLR, as it has got a public health Rutland representation, and the details of this are in the report. In terms of recommendations, we sort of recommend the monitoring of the access rates in particular, and perhaps doing a bit of a deep dive on sort of cross-border flows and access to private dentistry in Rutland. Also the main recommendation is improving access basic to NHS dentistry for the vulnerable groups. Targeted oral health promotion and perhaps looking at fluoridation through toothpaste distribution and even water fluoridation within Rutland. Yes, a particular focus on early years setting in view of these findings from the survey in the younger children. So yeah, that's the very sort of brief summary of what's in the reports, and we would love the board to approve the document and endorse its recommendations. Thank you very much. That's me.
Thank you very much, Hannah. If you could bear with us in case there's any questions. I don't know whether there's any questions or comments. I think Mike beat you to it just because I saw his hand first, and then Janet. Thank you.
Thank you, Chair. Not on the content of the HNA actually, Hannah, but just to come to the recommendations. I mean, I'm more than happy if IDG oversees it. I think within there, I just want to check up at 4.5, the health promotion service. We've kind of filled that gap. I think we've commissioned that within Rutland, so that one's done. 4.3 under that again feels like a public health within the county council kind of job. Just looking at Adrian, and then the other ones I'm thinking 4.4. I mean, that almost feels worthy of a bigger consideration because fluoridation picks up a number of issues, not least of which the perceptions of the public and politics and everything else. So IDG might be the starting point for that, but it's probably not the end. And then I just wanted to check with IDG, obviously with the transfer of commissioning responsibilities for dentistry, optometry and pharmacy from NHS England to the ICB in April. Or is it July? Well, is this year? Is it April? There we go, April. Just wanted to check in terms of who would be best for IDG to link up with, which Sarah is probably a bit of a shoe-in, just give an update on the transfer of responsibilities. Okay.
Sorry, Sarah, can you just put your microphone on?
I was just saying I was going to do a pods update as part of the ICB update.
Thank you. The fluoridation bit, I won't be able to say that. Jan, do we want an answer on the floor? Well, we'll come back to the fluoridation and then we'll go Janet and then Ian. Thank you.
Yeah, I've been asked to bring this to everybody's attention. On page 58 of the report, or page 232 in the reports pack, it's got dental access should be investigated further and steps taken to improve access locally with a focus on the elderly, men of working age, vulnerable groups, including families of the military personnel. I was asked to suggest that children with special needs, additional needs, should be included as a separate item on there. They're actually amalgamating the JSNA chapters and this one, I've worked out that there's 778 children in Rutland with the SEND. That's up to age 17. There's 530 people with learning disabilities aged 18 to 64 and 210 people aged 65 plus. I don't know whether you want to include in it the 218 children in need, but these are people who are particularly able to should be able to access NHS dental care. They've got the most difficulties in actually transport to dental care. And I think they need, well, we think they should be represented as a separate item if possible, as a separate group.
Thank you. I think Dawn wants to come in.
Yeah, just to come back on the figures that have just been quoted by Dr. Underwood, I don't recognise those figures, so I'm not sure where they've come from.
The JSNA chapters, the earlier chapters.
So we, in terms of, without getting into the detail, it depends how SEND, for example, has been defined as part of that. So what I, just off the top of my head, 302 children in Rutland have a education, health and care plan. So not the 700 and something that you've just said. So I think we just need to, there's some caution just around some of the figures. We don't have children need, I think you quoted 300 and something.
280.
Yeah, we don't have that. I've got Ofsted in at the moment as we speak. I've got 58 children who are subject to children in need plans. So just need to be very careful about some of the numbers that are being shared. It depends on what your what the definition is that's being used.
I picked some of these figures up from the JSNA Health Inequalities chapter earlier on.
We'll take that outside and have a look, because I must admit, when you were saying the figures, I was thinking, I don't recognise this from the meetings I go to on, and sitting in quite a few of the children's meetings with my other hat on as children's champion, I didn't recognise, and certainly not 200 children in need. That made my eyes water.
I don't know the figures, what they are, but that's what's in the papers.
Yeah.
So there's an correction made.
That being said, I do agree there is an issue around children's dental health. So what I would say, that's the important thing, as opposed to getting sidetracked with the actual figures. I just didn't want people to think there was huge numbers when perhaps there isn't, but actually it is about kind of children's dental health needs, and they should be included.
Yeah, absolutely. I'll just, Mike, did you want to come back on this point exactly? If not, I'll bring it in.
I mean, we do need to sort of look at this outside the meeting, but I'm with Dawn. I suspect the answer is it's a confusion of kind of what's thresholds and what's kind of definitions. But the point made is we shouldn't get tied up in a definitional debate when you've got your figures, but there is an issue which we do need to do. Yeah.
Yeah. So we'll do that as an action, that we'll just bottom out some of those figures and see how they link up. And it might well be, as you say, definitions and thresholds. I'll just bring Ian in. Thank you.
Thank you. Yeah, excellent report. Thank you. And quite an easy read. In terms of how it describes the armed forces situation, it describes it perfectly. That most of the service personnel, the regular personnel, are completely provided for with regards to dental care. But it highlights, and I'm grateful the report highlights, that there could be an issue with armed forces families, in that with churn and with an increase in families, accessing NHS care could be problematic. So I'm grateful the report does that. Just following on from the children's point again, armed forces families bring a lot of children with them. The only other thing I'd say about the report, and I'm sounding like a broken record, I'm afraid, but if we could avoid the term military and use the term armed forces, just so there's no misunderstanding, because sometimes people just think the military is about the army, and it's not. So if we use the term armed forces, I'd be grateful.
Thank you.
Thank you.
We'll do that as, did you see, because sometimes I know you pick up that much more than I do. Have we used the term military in here? We have. So could we do an action, if it's not too much, just to control an F and swap that? That would be fantastic, Hannah, just to do that, because Ian is correct in his thing. So we'll lead by example, if you wouldn't mind. I hope that it doesn't give you too much more work. Were there any other questions, observations? No. So we've got a couple of action points. Just one thing, obviously, and Sarah said she's going to pick up some of the timeline with the ICB picking up ownership of dentistry. I am very aware that today in Rutland we will have children and adults with a sore mouth who can't access dentists. I did read on social media, someone travelled 2 hours this week in dental pain to try and get a thing. I really welcome this JSNA. I would thank Hannah and the team for all the hard work. They really have reflected what it's like for Rutlanders at the moment. Unfortunately, we don't offer any solutions, and all we can say is that hopefully with the recommendations, with the work that I know the ICB are going to put in, that we can start offering some solutions. I know some of these recommendations are certainly around providing up-to-date information on NHS dentistry. I think certainly we need to just double check that triaging is in place. I know we've had reassurance upon reassurance that dentists are triaging people anecdotally. I'm not sure that 100% of people who are ringing Rutland dentists are being triaged. So I think as a board, if we can pick that up and if we can, again, promote that so that Rutlanders know the service they should at least be expecting in the interim. And then we will champion for services to improve. We're starting from a low ebb, unfortunately, so the only place we can really go up is upwards at the moment. I know specifically, I did ask Dawn, and I'll put it up. It was for those outside who don't sit on some of our children's at corporate parenting board, we picked up dentistry. It is something that is kept an eye on through corporate parenting board. Currently, our young people have been seeing a dentist because we've had. Do you want to come in? But that some care has been accessed privately to ensure that they have had service. So it is something that I had asked for us to have some data around how many of our young people we are paying private dentistry for in order that they're seen, and that should be highlighted. So I think. If we'll bring that forward, we've got those other 2 action points that I'm hoping Jane has written down. And then if we're happy with no more comments, I will close that section. Just again, thanking the team for a great report. So I'll close it. We'll approve publication of the oral needs assessment and we'll endorse the recommendations to the IDG to consider and progress as required, the ICB to pick up. Are we happy with that? So I'll propose it. If I could ask for a seconder. Thank you. I saw Dawn's hand actually first and then all those in favour. Thank you. Thank you. And now I'm right to thank you very much, Hannah. You can leave and go and have a cup of tea now. Thank you very much indeed.
Thank you very much.
We'll now move on to item number 9, which is the integrated care system update. I think I'm over to Sarah Prima for the verbal update. Thank you very much.
Thank you, everybody. I'm just going to touch on 4 things, I think, today. So just a quick update following the December meeting of this board on where we've got to with the integrated care partnership strategy. So as you remember, we discussed that in December in a special meeting. It was considered by the Health and Wellbeing Partnership in December as well, at which it was decided that the City and County Health and Wellbeing Boards would consider that strategy before it was put out for engagement. So City are considering it, I think, on Thursday, And there's a date in the diary, I can't remember the exact date, but it's in February for the county board. We'll then collect all the feedback, including your own from December, tidy up the document, and it will go out for engagement. Timelines will depend on PERDA again, with a final version being considered hopefully in the summer or early autumn of this year, depending on how much feedback we get and the timelines around PERDA, etc. That's a bit of an update on the ICP strategy. A little bit more about the 5-year forward plan. So the 5-year forward plan is required to be produced by the Integrated Care Board. It sets out effectively their plan to deliver services and transform and to become sustainable and deliver on their requirements, their duties, if you like. The requirement is to publish it in a final form by the end of June, but we will need to do something. We have to submit a draft to NHS England in at the end of March, basically. So there is a requirement for the Health and Wellbeing boards to consider that strategy. So again, we just need to work out, I think, with the 3 chairs of the Health and Wellbeing boards, how we do that in a timely manner that fits the requirements of the timescales, but also gets your feedback into that. But from our perspective, that will really look at the key things that we need to do over the next 5 years to make us more sustainable in terms of our service delivery and financial position. And then the third thing I just wanted to touch on, which was the pharmacy, optometry and dentistry changes. So currently, as most of you will be aware, NHS England commission those services. They will be fully delegated to us from the 1st of April. So currently we're going through a process of finalising the governance arrangements for that, which is probably going to be through a joint committee of the East Midlands ICBs, and that is likely to go to our board in February. I'm just trying to tie up the final bits in relation to that now. So that means that we will have commissioning responsibility for those 3 areas on the 1st of April. So things like dentistry will be the responsibility of us, although we will discharge the delivery of those services through a hosted team across the 5 ICBs in the East Midlands. But the accountability sits with the ICB, the delegation sits with the ICB. And then the 4th thing I just wanted to touch on was I'm going to just give you a little bit of update about winter actually, and how things have gone. So obviously, like all areas, winter has been challenging, like winter is most years, particularly around Christmas time when we had the peak in flu and the respiratory, the children's respiratory period. And then obviously following that, we've had some industrial action. It didn't impact on RLR as much as it did in other areas, to be fair. But in terms of responding to the general winter challenges, there's a few things that we've done. So we've established a system control centre that is helping to coordinate the system on a daily basis in terms of its response to the demand and capacity that we might have. We've established some additional capacity across a range of areas. So we've had additional appointments go into urgent treatment centres. We did a piece of work just after Christmas around additional capacity to support the children's surge in respiratory disease. We've put more resources into the pre-hospital services, particularly around unscheduled care and the pre-transfer service that we've got on that supports people in their own homes rather than taking them to hospital when they don't need to go. We continue to actually have low conveyance rates from EMAS into the hospital, and a lot of that is related to the work that I've just talked about in terms of what we've done to reduce demand of actual 999 ambulances and try and keep people at home, because we know that's the best place for those that can stay at home. And we've put some additional capacity into A&E so that we can hand over patients quickly and easily. And we've also, as we talked about actually as part of the questions, we've got the work that we've done in conjunction with our local authorities, including Rutland, around supporting people to get a timely discharge, wherever that may be, to suit their needs. So they were the 4 things I just wanted to touch on. I'm happy to take any questions.
I'll quickly jump in with a couple of my own before I forget them. Just on the strategy, the joint strategy, can you check with the team? Because I never sent it, but I might have sent it to the wrong email address. Can you just double check with the team that you received our feedback shortly after the meeting?
I don't think we have. Do you want to send it to me and then I'll make sure it gets the team? Yeah. I was going to give them the minutes actually from that are attached to the pack today, so they'll have those. But if you send it to me, I'll make sure it's got there.
Yeah, because I'll do that afterwards. Yeah. And then I suppose that the other thing is, and we can bring it. We'll probably move it to the end, but just around timings around March and whether we'd have a draft that could come to the March meeting, which is 22nd. I want to say the 22nd. If that would be really handy. 21st. So I suppose whether we might have a draft then for that. I'm
not sure. Well, we should about have one by then, because we need to submit a draft at the end of March. It's whether we've got it in time for your papers. That's the problem. We should be about 10 days before, won't it?
Yeah, I think.
If we speak, Sarah, because we can work around it.
Yeah.
We can send it as an addendum.
Okay. Okay, let's work. We'll have a discussion. Yeah.
Let's work on that, because I'm conscious that PERDA will start on that Friday, the 24th. I think we're going into PERDA. So that 21st meeting is probably us pushing the boundary to. Yeah. And then my one other thing, and it refers back to dentistry. Obviously, it's coming to the ICB and place obviously on the 1st of April. It doesn't come with a magic wand, unfortunately, and I think just means we'll get all the flack from the 1st of April. Yeah. I wondered whether we could have, and you might well not have it, and that's fine. We could maybe bring an update to the March meeting of maybe a plan of how and when and what it's going to look like, and how whether there's light at the end of the tunnel on it, bearing in mind we've already established some of it's down to contract, and that's not gonna, there's no magic wand on that. So it's, I suppose.
Do you have the did NHS England come and speak to you about dentistry, or was that your HOSC?
No, yeah, to be fair, NHS England have never come to our health and wellbeing board. They have come to scrutiny, and they have never come to health and wellbeing board.
That was a really detailed report actually, with all the actions in it. So we could ask them to come and present that.
I think if they're coming to present that in March and they're finishing in April, I'd probably think what
the actual full report and the presentation from NHS England regarding dentistry is published on the council's website on the scrutiny meeting page.
Deb, do you want to come in?
Chair, it might be worthwhile them coming in March, because those actions that were in that report, they should have still been working on. So it would be a good handover.
And it will be the same people actually. It's you know, the same people will be working on those actions on behalf of all of the ICBs.
Okay.
It's just been delegated to us. The people will still be the same people.
We'll put that on as possible. We'll come back to it when we're doing the forward plan then. It might well be that we invite them. Thank you. Sorry, that was my 3 questions. I jumped in ahead of everyone else. Apologies. Does anyone else have any further questions? No. Thank you very much indeed, Sarah. So moving on to agenda item 10, which is the joint health and wellbeing strategy. There are 2 parts to the agenda item. Firstly, we'll have a report from Catherine Wilson, giving an update on the strategy, and then we have a report about the proposed communications and engagement strategy plan. Catherine, over to you.
Thank you. So the joint health and wellbeing strategy is progressing. We've been working closely with the priority leads on getting some quite clear objectives and measurable objectives, so we can actually show to the board and to members of the public progress. Next steps around that is actually pulling together an annual review. So I'll be starting to work on that with priority leads in the next couple of months. So we want to be able to show what has been achieved and also clear progress toward achievements. Really need to focus on priorities within the strategy. I have pulled out a few positives, good progress within the delivery plan that are in the report. A couple of those, for example, is the Children's Centre has been identified as Rutland's first family hub, which supports health child development from conception to 2 years. Funding has been secured for a coordinator in Active Rutland. This is for exercise referral, so this is all about promoting personal activity levels. There are a number of positive elements moving forward in the plan. We do also have some challenges, a couple again of which I've mentioned. It's still sometimes a challenge to get engagement from all those responsible for delivering on the plan. We are working hard to get that engagement. I'm offering support where it's required, but it really will be pushed, because I'll be saying that we will be doing an annual review and there'll be an expectation that we will see some progress in all of those areas within each priority. The outcomes summary report as well, I've referenced in the paper. Again, there's some really positive performance and some other poor performance areas. But really, again, next steps is for the priority leads to be working with public health to see how we can make some improvements in those areas that are poor performing, but also to maintain the areas that are performing well. Because as you can see, there are some red areas within there we need to start trying to make improvements on. Just to note, the amber areas don't need to worry about too much, because Rutland's a small area, the statistics can get skewed. So we do need to focus on those red areas. Yes, so it's just for the board to note progress on the plan and the outcomes report and further work required.
Thank you, Catherine. Do we have any questions from anyone? Mike?
Yeah, thanks, Catherine. Not so much a question, more an observation. I mean, I'm just flicking through the outcomes report, and if there's areas that crop up consistently, they relate to vaccination and immunisation coverage and cancer screening programmes coverage, both of which are responsibility of NHS England and not coming the ICB's way for a while. So I totally think you're right. The subgroups need to get a grip of the reds. I'm uncertain how we bring pressure to bear at regional level on NHS England to pay regard to Rutland's performance. Can't put it better than that.
Yeah, thank you. Absolutely. Some of these areas have been poor performing for some time, haven't they? Which is why I think we need to at least start to consider how we can work together and make some improvements. Haven't got the answers at the moment.
Thanks. Dawn, did you want to come in?
Yeah, thanks, Chair. Yeah, agree entirely with what Mike's just said. Just in terms of the children care immunisations, the percentage is skewed. We've got low numbers, but we've got a high proportion of unaccompanied asylum-seeking children as a cohort of our looked after population. they will be marked as not being up to date with their immunisations because we don't necessarily have their immunisation history. So I'm kind of, it's difficult to see how that will ever be 100% because we don't necessarily have an immunisation history that allows us to say they're fully up to date with their immunisations. What I can give assurance on is that when children come into our care, we endeavour to give them the immunisations that their age requires. But just so the board, just to give a bit of reassurance in terms of the board, that does make it quite difficult for us to hit that 100%, which is, of course, is where we want to be.
Thanks, Dawn. Janet.
Yeah, it's just, I was asked to say this as well, just to ask and note that people in Rutland, our feedback that we're getting is that they're desperate for more services to come closer to home and not have to travel to Leicester and Peterborough and wherever. If there's any way any of that can be sort of prioritised, I think Rutland people will be really pleased. I think there's been some good feedback about the MRI scanner and the potential for the MRI scanner. I think people are really quite pleased by that, but it just seems slow progress sometimes.
Thank you. Deb.
Thanks, Janet. Improved access and local access is very high on our agenda. We do have to balance that with provision of services across LLR, but we are looking at the opportunities around diagnostics and some of the elective services locally. There's a piece of work going on around the feasibility of Rutland Memorial Hospital and what we can do more in terms of availability of clinical space and what would then be appropriate to bring those services forward. So there are actions in the health plan and in the joint health and wellbeing plan linked to improved access. We have, of course, had a more GP outpatient appointments as part of extended access. And as of this week, or it might be early next week, there will be a acute respiratory hub for the remainder of winter taking place in Uppingham Surgery, which will give access to additional appointments for all Rutland residents with acute respiratory infections, which will stop them needing to go further afield to either A&E departments or urgent care centres.
Thanks, Deb. That's great news. David.
Thank you. I just wanted to come back just to help everybody be clear. I guess, Deb, I just wanted to pick up on a word that you've just used that people may misunderstand. And you talked about a feasibility study for Rutland Hospital. And I just want to clarify with everybody, this is about investment going into Rutland Hospital. 1.2 million of refurbishment happening already. We're expecting the refurbished wards to open at the end of February. And actually we're all having conversations about what more services could go in. And I'm just sort of conscious, I think before Christmas, people misunderstood some of the conversations that were happening. Everything we're doing is about more services going into Rutland.
Thanks for that clarification, David. Janet.
Yeah, could I just come back? One of the big things that we picked up when we were doing the What Matters to You project was that people desperately want to be able to have their ophthalmology at Rutland Memorial Hospital, if possible.
We'll feed it all in the ways of working and building everything in. There is always going to be the real challenge about making sure that we can deliver safe, quality services in locations and the ways they work. But absolutely, everything's been trying to think about what can we get with care as close to home.
Yeah, and I'll say, obviously, I can imagine people don't want to travel for ophthalmology, but as a regular visitor to the A&E at Leicester Royal Infirmary, I can state it's a fantastic service there, and actually they have all the machines you could possibly want, and I don't think we'd be able to replicate that service locally, and that is part of the problem, that the eye hospital at LRI is so specialist now, and actually is a one-stop shop. You can be in and out within 4 hours, having every test under the rainbow in there, and I think that's the thing. It is a clear balancing act between top rate service and care close to home. But I appreciate the problems, and there'll always be that wish. But it is that is something that the ICB has to weigh up, and the hospitals where
Yeah, I think it's not so much the emergency care that people wanted. It was people telling us for their routine, like eye injections and their routine. I don't know what else they, but eye injections were specifically noted. I think at the moment everybody has to go through to either Peterborough or Leicester for something that is potentially quite a routine procedure.
I know as part of the plan there is a look at outpatients and what is feasible, so that will feed in. I think they're looking at every part of outpatients to see what can be delivered close to home, so that would be good.
The other thing that came up in the What Matters to You project was, and I'm just throwing it out there, I'm not saying, is that people wanted to be able to have potentially remote access with a consultant, but taking place in a room, say at Rutland Memorial Hospital, but supported.
Yeah. Thanks, Deb.
So that's one of the things that we want to pick up as part of the levelling up bid, and the opportunity there of using digital technology, remote back into UHL and possibly Peterborough Hospital. So it's certainly in our line of sight.
Thank you. Any other comments or questions? Catherine.
I think it's coming up quite a lot, access issues. You're feeding it, I know, and across Health Watch, feeding it to other groups as well. I'm just wondering, it might be worth at next board meeting having a focus on that area of the strategy and delivery plan.
Well, hopefully the RMH feasibility study is going to be presented in March, which will make it a bit clearer give a few clearer expectations, and then I'm just a bit, I think we're not quite there in, I think, marrying up expectation to reality, I think, is the unfortunately, and I think we just need to be a bit clearer. I know the primary care review that's going on, a states review has been delayed, but I think we need more of the jigsaw pieces, I think, before, but I think for future it would be very much a case of having an access meeting. I don't think we're quite in a position with all our jigsaw bits yet to put the puzzle together in a meaningful way. I think we'd have more holes in the jigsaw that we can answer at the moment. So I think that's a great idea that we could hopefully carry forward to next year. But I don't know what others think, but I think we're just a little bit away from that at the moment with the jigsaw pieces. And I think it would, residents would get more frustrated, I think, with it rather than it being helpful. I think Deb agrees and things. So any more, I don't think, any more comments on the note? Thank you. So I'll draw that discussion to, and we'll note the further development of the delivery plan, and we'll note the latest Rutland's outcome report. And then after we've noted that, I would like to just have a little chair's moan. I'm going to call it the chair's moan. Obviously, it's really important that the delivery plan is fed in so that as a board we can recognise how far we are along the journey and we can audit along. There are some parts where we might be slightly struggling to get updates on time. The templates have been done. They this is the first time they've been used, and everyone the feedback I think that we've had is that they've worked quite well. What I would ask all our officers here is that you feedback to other officers the importance of timely reports back. As we've already stated, and as Sarah mentioned, we have to have these papers to be published statutory. These papers have to be published a week before. That they're during our government's 2 weeks before. We did get one update an hour before the meeting started. That unfortunately is not much use to us because it can't be fed in, nor is it part of the papers. So if I could ask for support from our officers here, that you pass down through the kind of chains of command, the importance of coming to the Health and Wellbeing Board and us highlighting if we can all take ownership of those updates from our organisations and our teams. I know it's quite difficult, the amount of work on at the moment, but it is really important that it is because it identifies the good work actually that all the organisations have done. There we are, chairman over with. We'll revert to the next one. Thank you. So next we've got the communication and engagement strategy and plan. I'm back over to you, Catherine. Thank you.
Thank you. I just wanted to bring this this month because we haven't had an update since the summer last year. The plan was actually brought to the Health and Wellbeing Board in June or July, so it has been seen. What needs to happen, it needs to be finalised through agreement with stakeholders. So that's the main consideration for the board today, for me to be able to share that with stakeholders, get their consultation, look to get the plan finalised, and bring it back to board as soon as possible. We are progressing with it now. We have got the working group getting back together again on the 30th of January, and I'm hoping that will really, with everybody working together, that will move forward with the delivery part of this plan. As you can see, it covers around readiness to deliver the plan, ensuring people have access to the information they need, raising the profile of the Health and Wellbeing Board, and involving the public and professional stakeholders in service design and change. And we now have input from Rutland County Council's communication and co-production and engagement lead, and also some quality officers. So working really hard in actually getting out into the community and engaging with people, finding out what their views are. I know a lot of that is happening already, but also ascertaining where people are prepared to actually use their lived experience and contribute to designing of future services. Big part of it is around digitalisation and access, and also scoping out what there already is in the community, so we're not duplicating. Particularly important is linking up across the system with LLR, so we are having meetings with partners across the system as well.
Thank you. Any comments, Mike?
Yeah, just one. I mean, as part of that kind of system coordination, I don't really know if I want to tread here. Does that involve explaining to local people exactly how the Health and Wellbeing Board and strategy fit with the integrated care system and the board? And if you can explain that, good on you.
I feel I've been given a challenge. Specifically, it's something we'll consider.
I think we should, and I'm looking to Jennifer, I'm sure would probably agree that we do need to give some. I'm mindful of your comment about where does the health and wellbeing strategy fit with the capital plan, and there is a link there which I think we need to describe. Yeah.
Very much so. Any other comments? No, I think, thank you very much. I think we welcome this. It would be good, and it wouldn't need to formally come back, where I wouldn't suggest, but it would be good once the working group has met and that you're engaging with stakeholders, that maybe you could email around to members of the board so that we know where we're going with that and there can be any input. And it may be that colleagues around the board may have some other stakeholders that they feel may offer benefits, so that it would be great if we could share that and then come back at a later date once that's the stakeholder stuff's been done. That's great. So we're noting the content of the report, and we're noting the progress of the Health and Wellbeing Communication Engagement Plan towards being finalised, and the input from stakeholders. Thank you. And now we're on to item 11, which again, Catherine, is you, and it will be the report on the Better Care Fund. Thank you.
Thank you. Firstly, to note that the annual plan 2022 to 2023 BCF plan was formally approved this month by the NHS England. It came after I did the report, that's why it's not in the report. This is specifically around, as we discussed right at the beginning of the meeting, around the addendum to the Better Care Fund, the discharge fund. So this was announced in the autumn statement that £500 million would be made available to local authorities through ICBs. It's particularly focusing on hospital discharge and to the aim of getting people home wherever possible or into rehabilitation rather than using residential care beds. In Rutland, we have, as Councillor Harvey mentioned at the start, we have commissioned 4 beds in Rutland Care Village for reablement purposes. They're being really well utilised and we're getting really good outcomes from those beds. People are well on their way to returning home, and the therapy input in there is really positive. And there are other schemes such as more flexibility around domiciliary care. So we can provide overnight care, for example, where it's required. We work really hard across LLR to get consistency and to have schemes which benefit the whole of the system. So things including promoting home first to hospital staff, which is the route to get people home using care, etc. And also bolstering up the discharge. Sorry. Sorry.
Discharge to assess? No. I'm queen of forgetting words, so John, can you help?
The discharge hub, sorry.
Discharge hub.
The discharge hub. So there's more capacity in the discharge hub to help with flow and particularly around therapy. Sorry, everybody, blank moment. Yes, so, and we're having to do fortnightly reports to NHS England to show progress specifically around discharge numbers and utilisation of the discharge fund around care hours, usage of beds, etc.
Thank you. Any comments, Deb?
Thanks. It's just worthwhile making a note that this is one area that Rutland really do shine, and I think it was picked up as part of the response to the question earlier. We have very, very few delays in Rutland, and that's because of the really good partnership work between health and social care that's been going on for years, actually. So although these amounts of money look quite small to Rutland, it's in recognition of the fact that there's a really good service and working relationships and pathways that already go on in Rutland. So yeah, and this latest tweak and development, I think, has just improved the service even further.
Thank you very much, Deb. Any question, Janet?
Yeah, I just wondered how the staffing situation in social care is for you. Have you got as many people working for you as you'd want? Too many vacancies, or?
John, I'll bring you in.
Yeah, thank you, Janet. With our own services, we're quite fortunate that people like to come to work for us. So in our reablement service, we have no vacancies, and our My Care, which is our My Care service. Our occupational therapy service is all, I think that's full capacity, which is also part of reablement. Social work wise, it's a little bit touch and go, but it is across the country currently. But we're confident that the interest that we've had in our recent, I'm doing a U now. In our recent recruitment drive is positive. As for the private sector, we have good domiciliary care capacity. We work very closely with our domiciliary carers because they are also part of the system, and we do them and ourselves a disfavour if we see them as separate. And that's also the same with our care homes. I haven't been hearing any reports, unless any of my officers over there can tell me different. I haven't been hearing of any reports that would contradict that.
Thank you. Any other comments? No, I'd just like to say and stick my portfolio hat on for a second, and I'd actually love to thank the team. I'll thank Catherine for the BCF. Anyone that's witnessed and chugged through that knows how tricky it is and how much reading and stuff it takes. So thank you for the hard work getting that in on time. But I really would like to thank adult social care teams and Karen and Kim and Matt in particular for moving really quickly and coming up with ideas. The beds idea and everything was fantastic and does make a difference. The reason we're so good at discharges and keep getting our Rutlanders home is because our teams work so fantastically hard, but also that they've developed the relationship and that they see the people. I think is essentially every person is a person rather than a name on a page, and that makes a huge difference. So I am really, really proud to lead the portfolio. So thank you. So anything else? No, I'll put my chair back on. Thank you. So we're now on to, we've got a note. I've got to note the contents of the report. We're going to note that the 22-23 Better Care Fund, Adult Social Care Discharge Fund planning template, submission of which the BCF national team to the national team on the 16th of December, that was signed off by me. And then we're also noting the 22-23 BCF Adult Social Care Discharge Fund first report, which was submitted to the national team on the 6th of January. Thank you. And we've heard back, you said, haven't we? And that's all been signed off now, hasn't it?
So far, so good.
So far, so good, yeah. Thank you. So on to, we're not doing too badly. I hate to say it, I'm doing all right for time for me. I'm not jinxing it, but I'm saying. Update from our subgroups. So this also includes the terms of reference, which we require the board's approval on. So firstly, I'm coming to Councillor Wilby for the Children and Young People's Partnership.
Yeah, thanks, Chair. You've all got the draft terms of reference in front of you, or you will have had a chance to see it. Our group is working really well. I was very pleased to chair a very vibrant meeting quite recently, and I was really pleased with the inputs that came from everybody around the room. And of course, for a partnership to work, it does require all the partners to turn up and make sure that their stuff is there. And I thought it was a good turnout, a good representation from everybody. And we look forward to being able to keep you updated with how things are for our young people in Rutland.
Thank you very much, Councillor Wilby. Do we have any questions on the Children and Young People's Partnership terms of reference? No, we all happy? The only question I've got, and it was an afterthought, so apologies, and it will stand for the IDG ones as well. For the Health and Wellbeing Board, we have two statutory responsibilities, one being the Joint Health Strategy, but the other being the JSNA. The Joint Health Strategy is obviously mentioned in here and in the other subgroup. We don't actually have any responsibility delegated to subgroups for the productions of the JSNAs. I think formally because it's seen as a public health role. So I didn't know whether we wanted to integrate them, or are we happy with how it sits now, that the board will delegate it down as and when, but it sits with public health. I just thought it might be worth, because it is obviously those two being subgroups of the Health and Wellbeing Board, by kind of definition, they would also have a slight ownership of the JSNA as well, as we all do. I think Dawn wants to come in and say, no, Sam.
Read my mind. I think it's more about the ownership of the JSNA being with the Health and Wellbeing Board. That's the important bit. But obviously IDG and Children and People's Partnership will feed into the JSNAs, and I think that's the bit that that's the important bit, rather than a delegation as such. I don't think actually a delegation would be helpful.
Yeah, if Mike's happy with that, then we'll chair will shush. And I wanted just to raise it for both of them, because we hadn't raised it before, and they were published and I was reading through, and then I thought, oh, hang on, we haven't done that. So I just wanted to ask. So if I'll take the nods that we're happy with the children's. So thank you, Councillor Wilby. We'll move on to Deb and the I'll take the vote separately. So sorry, if I'm going to take that Councillor Wilby, what's the word? We're all having it now. It's too hot in here. Propose, thank you. It is too hot in here. I think we're all melting. Councillor Wilby will propose it. I'll second it for him, and all those in favour of those terms of reference. Yeah, we're happy. So we'll move on to Deb, please, for the integrated delivery group terms of reference.
Okay, they're set out here. The only comment I'm going to make, and I'm probably going to regret making this, and it's a question really to the board and to you, Chair, particularly. The three terms of reference that are in here all have slightly different formats. And whilst the content, I think, I'm more than happy with the content of all three of them, I do wonder whether you're happy with them being in different formats. I'm kicking myself here by raising it.
I think, well, have we got any comments from the, I can understand what you mean. I think it's great that we've approving the terms of reference, so that there we've got, I think what we could do possibly is in a year's time, we could maybe relook at them, and then maybe we could bring them, if we wanted to be pedantic and bring them into the same format, we could maybe look at them then to bring it. But I think I'm happy I've got them. I'm a happy bunny with that.
Sorry, Chair, what I could say is if you want to review in a year, what we could do then is just create one set template for all groups to use, and I can help with that.
We could do that, because then we've got, I know further on the agenda, we've got another couple of terms that are terms and reference. So that might well be worth doing. So if everyone else is happy with that, we'll do them. So if that answers, and then we'll move back to the terms of reference.
So just to check, I'm proposing that we sign those off if everyone is happy, Chair.
Any questions on these? Everyone's nodding. So if Deb, you propose, I'll second again. So all those in favour? Yep, we're happy.
Chair, did you want an update as well, or were you just doing the terms of reference?
Yeah.
Sorry, Chair.
I'm messing this right. I'm really hot.
I'm going to just be really pedantic.
Pedantic away.
Just under the membership of the IDG, can we stay away from names and just go with roles, because names change, and I think roles are probably just what's needed as opposed to the actual names.
Yeah,
very good point, and we'll get those changed.
Yeah, we can just, that's delete column, isn't it? So that's easy enough. Yep, that's great. Do we want, so is there a quick update from Children's Partnership in regard to work, or it was incorporated, wasn't it? Oh, sorry, I'm looking at you, Dawn, but it's Councillor Wilby.
I'm happy I've given you an update, and that you've got enough on your plate to not dive into the detail.
Thank you very much, Councillor Wilby. Deb, have you got a quick update as well? Thank you.
Yeah, just a couple of points, Chair, and a few of the things I was going to raise have already been picked up, one of which was the dementia and the JSNA communications plans. We were pleased to have a good discussion around the communications plan and the move forward, which we've already covered. We had feedback from all the work streams using the format reports, and absolutely taking the chair's moan, we will pass back the comment about timeliness of the reports, but just in acknowledgement of some of the difficulty that people have had, we've since had agreement that we are going to completely merge the reporting of the health plan and the health and wellbeing strategy, the health elements, which will make it much simpler for people to report back on. So that covers that element of the plan. We also did a discussion around risk, and we will be bringing a combined risk report back to the next IDG from all of the areas of the plan. And we agreed to add a piece of work to the equitable access work stream to look at EMAS waiting response times for category 1 ambulance call outs, in recognition that Rutland times are longer than LLR overall, plus other rural areas served by EMAS. So we're going to do a piece of work around that.
Thank you very much indeed. That will be most welcome. Any comments from anyone? No, thank you. So next, I think we've got Emma Jane Perkins, who is online. I think we're just going to pop you through, Emma Jane, and she's going to present a report on the Rutland Mental Health Neighbourhood Group. And there she is.
Good afternoon.
Hello,
everybody.
Emma Jane.
Hello there, and thank you. I've been listening with intent to the whole meeting, so it's been very, very interesting. I'm just presenting the opportunity, hopefully, for the Rutland Mental Health Neighbourhood Group to be a formalised subgroup of the Rutland Health and Wellbeing Board. In your pack of papers, you have had an update of the group, its terms of reference, which I acknowledge are in a different format maybe than the other two that have just been presented, but happy to work with Jane to amend that. The Rutland Mental Health Neighbourhood Group has come about because there is significant transformation happening across LLR for mental health support services. And very much part of that transformation is to bring things to what we call the place. So it's really important that we work with our stakeholders to implement a place-based mental health strategy, and underpinning that, a delivery plan. Now, this isn't going to be another plan that sits alongside everything else. It already is incorporated to some extent into the Rutland Health and Wellbeing Board plan under priority 7. There are a number of overarching parts that touch mental health. It also, we make sure that it is all age, and that it will be consistent with the Children and Young People's Partnership Plan, and obviously the Integrated Development Group and all of the other 6 priorities sitting within the Health and Wellbeing Board. We're coming to you to say we'd love to be a subgroup of the Health and Wellbeing Board to ensure that it has proper governance, and we can report on where we are up to with our strategy and planning accordingly. The strategy is very much in its infancy. We have been working with our stakeholders over the last couple of months to really get to grips with what we want the group to be, what we want it to be developing, and that's what's in our terms of reference that was in your paper pack. We are now working on what the strategy might look like, and making sure that it does meet all of the needs that are identified in the GSNA and the health inequalities work that has been done at depth through our public health colleagues. So that's just an update, Chair, to say you have all of the papers in your pack, you have the terms of reference, and our proposal is for the Rutland Mental Health Neighbourhood Group to be a formal subgroup of the Health and Wellbeing Board.
Thank you very much indeed, Emma-Jane. Is there any questions? Mike?
Yeah, thanks, Chair, and thank you, Emma-Jane. Totally supportive of making mental health the 4th subgroup. I think it's really deserving of the same level as the other ones. Couple of points really. I mean, I'm sure this will evolve as the group does. I was looking at the slide on page 331. If I make that 23 strategic areas of focus, which feels about 19 or 20 too many, but I'm sure that will slim down, and particularly I'm looking at the ones where there's probably about adding a mental health lens to other people's work. I'm particularly thinking of things like cost of living crisis and indeed armed forces health as well. So I suppose there's a check on that one. And then the other one is just what's in a word. And I'm mindful of a conversation we were having in Leicestershire this morning when the children's lead member, when we were discussing mental health, did sort of make a point about it really should be mental health and emotional well-being to reflect that kind of broader range of conditions and societal issues as well, which the subgroup might want to look at. So I'm not pushing for it one way or the other, but I'll just pop that out there and see what the group thinks.
Thank you. Do you want to come back, Emma-Jane, or are you happy with what Mike just said?
Yeah, thank you, Mike. And the slides that are in there, there is a huge, great list of the sort of people and the sort of areas that we want to focus on. It is merely a list at the moment. The strategy hasn't been written. We're mindful that we don't want a 57-page strategy. We do actually want a succinct strategy that actually focuses on the most important needs at those points of time. So it is a list to acknowledge that there is a huge breadth of area that mental health covers, and you're absolutely right that a lot of those are picked up in various other forms, and there will be links across to them rather than duplication or replication of what's already been done.
Thank you. Any further comments? No. So we are approving the mental health neighbourhood group as a subgroup of the Health and Wellbeing Board, and we're also approving their group's terms of reference. I'll propose that. Do I have a seconder? I've got John, and all those in favour. Thank you. Welcome, Emma-Jane. You are now a subgroup.
Thank you very much.
Thank you. So now moving on to item 13, which we have a report from Adrian Allen about the Staying Healthy Partnership. This is on our addendum bit of paper. I think it was the addendum report, if others have got that. And then I've got 2 copies. So over to you, Adrian. Sorry, I'm
Thank you.
faffing about with paper.
That's fine. Yeah, so it came out as an addendum that in the actual pack that came out originally was the proposed work plan, but the papers were missed out, so they came out as an addendum. Similarly to the Rutland Health and the Mental Health Neighbourhood Group, we're requesting that the Staying Healthy Partnership become a subgroup of the Health and Wellbeing Board to take forward a number of work streams around the outcomes of the inequalities chapter. So there is a paper there. I'm going to hand over to Mitch, who pulled the paper together, just to go through that with a recommendation that the board becomes a subgroup of the Health and Wellbeing Board. Thanks, Chair.
Thank you. So yeah, the main purpose of the group really is to have some focused time around inequalities, following on from the needs assessment, but whatever comes out of the development session next week. So we're not preempting what's going to come out of that, but we're going to discuss it next week, and we need a forum to take that forward, ideally as a subgroup of the Health and Wellbeing Board. We do also propose that the group focuses on primary prevention and the wider determinants of health, so social, economic and environmental factors. We are conscious that the people in this group will be very similar to other subgroups, but the whole purpose of setting up a separate group is to have that protected time around that preventative agenda, which we can sometimes understandably struggle within other subgroups because of the acute issues that we're all aware of at the moment. So it's mainly to give that dedicated, protected time to really focus on those agendas and really focus on that kind of primary prevention of improving kind of what's out there in terms of a health perspective and keeping people healthy and hopefully out of hospital and from other long-term conditions. So that's the main idea, and the wider determinant side of things, it provides that forum for us to really engage as a collective Rutland health and care system, to really input into things such as the local plan development, so planning for how houses, new developments are going to kind of come up across Rutland, and really kind of focus on that collectively rather than inputting from our own individual sectors or organisations, and things such as transport strategies, economy strategies as and when they materialise. So that's the main essence. We did meet, well, we have met twice now with the proposed membership just to discuss putting the terms of reference or draft terms of reference together, and to agree that purpose from there as well. So we have had that engagement already, and we wanted to bring that to the group now, the board, to really get that sealed if it's approved, to take that forward as a subgroup going forward. And just to be clear, this isn't a whole new kind of work stream. It is very much what's already in the strategy, already in the delivery plan. Inequalities are ingrained across the whole thing. So we want to facilitate that across the whole partnership.
Thanks very much, Mitch. Do we have any questions from anyone or comments? Mike and then Dawn.
Sorry, you know you're going to get one from me. So just remind me, so this is about the Staying Healthy Partnership being the fourth subgroup or a subgroup of the IDG. It's elevating it.
The fourth subgroup, yeah.
Thank you. Dawn, did you want to come in? And then I'll, Deb.
Yeah, it's just a comment about general and specific to this subgroup. General, we've now looking like having 4 subgroups of the Health and Wellbeing Board. I'm really conscious of people's diaries and actually having time to actually do work as opposed to sit in a meeting. In the terms of reference, it talks about Children's Services Head of Service being the representative level. I can't ask, I haven't got capacity in Children's Service to facilitate another subgroup at head of service level. So I think maybe that just needs a bit of thinking. I'm just very conscious that, yeah, people are busy and need to have time to do work, the delivery of it. So that's.
Thank you. Deb, did you want to come in on this? And then Janet.
So absolutely acknowledge the point that's just been raised. But if we don't have some focused effort on this, we will be firefighting and dealing with outputs continually as a health and wellbeing board, and we weren't getting the time or effort to be able to give this any justice in IDG. I think acknowledging that there might be difficulty with certain groups actually taking part, then we might need to find another way around it. But I am really supportive of this being a separate group to look at these areas. I do acknowledge difficulty there with time with certain members attending.
Thank you. Janet.
I really support the fact that there should be a stream for prevention. It's part of the NHS long-term plan, it's part of the ICS strategy, etc. Absolutely support it, but I also support Dawn's comment, because I know that from a Health Watch perspective, we're having to sort of say to some people, we just can't get to every meeting, and we're having to sort of prioritise which meetings we feel we can add the most value, but also get the most value. So I sort of support both comments. It is a difficult one.
Yeah. Sorry, Mike, did you want to come back?
Yeah, it's an interesting one, isn't it? I mean, I've got sympathy for all bits. I suspect the answer is it's the same as I'd say for mental health, which is we often debate for cross-cutting themes such as mental health, health improvement, health inequalities, whether it should be a standalone or whether it should be shot through other people's work. But as Deborah's just said, with the best will in the world, if you make it a cross-cutting theme, sometimes it doesn't get the attention it needs. I suspect the answer is, for me, I am supportive of it being the fourth subgroup. I think there is a challenge, and to reiterate what I said to Emma Jane about all the subgroups basically looking at what they're doing, because none of them really should be duplicating what others are doing. So if there's 4 agendas which overlap to a massive degree, that's the wrong answer. But there should be specific things which people come together, and I'm open to how they do that. It doesn't necessarily have to be a formal physical meeting. There are other ways. The point for me is it needs work on it, and it needs dedicated time. It shouldn't really be hung up on the length of the meeting and everything else. So, there's a bit of a plea, I think, for all the subgroups to work a bit differently and to think about what their agendas are, and to think about how much they add value to somebody else's work, and then just let it go rather than duplicate stuff.
Thank you. Adrian.
Yeah, I appreciate everything that's been said and share your concern, Dawn, definitely. I think one of the things that we've tried to do with the proposal for this is put that 6-month gateway review in, because one of the things that we're really conscious of is that if we're not careful, the work of this group is going to have an overlap with the mental health group. So we're working with Emma Jane to make sure that there is that clear line of separation. So we try and cut down the duplication, but not to say that this can be fixed within 6 months, but that 6-month gateway is really important, because if at that point it's found that there is some duplication and there are better ways of dealing with this, then that would be the time where we would propose this to step back and move the work through those other areas.
Thank you. Dawn, do you want to come back, and then David wanted to come in?
Yeah, and just to clarify, it's not that I'm not supportive of the work stream and the work that needs to be done around inequalities. It's more the kind of practicalities of how we do the work. That was where I was coming from. But I think it's about how we can flexibly do the work and get together to be clear about direction, progress, and who's doing what. But I support the need for the work on specifically on inequalities. Absolutely.
Thank you, David.
Thank you. It's been covered, because I was going to say that I thought Dawn said she did support the work. You've gone and said it. I just wanted to be really clear. That's definitely what I heard.
I'm not going to say I don't support work.
No, it was the practicalities of making it happen was your query, and I think we've talked that through. I think Adrian's summary was really good.
John.
Yeah, also just to say I do support this being a subgroup. The prevention aspect, obviously it cuts across everything, every age group, and indeed the whole infrastructure of the county. Starting with Dawn's point is very valid, and also just to echo what Mike said, because I think Mike might actually have the answer there. In Rutland, we are a very tiny council, and we don't have very many staff at all, and we simply cannot field the amount of people, the amount of professionals that other organisations do. Very often, the ones around this table indeed, very often we have to make ourselves a little bit unpopular and say, no, we can't come to that one because we're actually down with 3 others. So what we have to do is to work differently. And I think if we can work differently, as Mike said, then I fully support this.
Thank you. No, I agree. I think it is really important. I think for too long, Rutland has been seen as an affluent place with no inequalities. And I think with regard to funding and lots of other things, it is really important that we do put inequalities kind of forward and we really are able to look in depth at it. Just a piece of housekeeping, because my guru on the left will tell us the Constitution is clear that we have 2 main subgroups and we can have other subgroups as we determine them, but we have to relook at them. So with regard to agreeing the mental health and this subgroup, there would be a need anyway to come back in a year. Constitutionally, I would suggest, I know you've suggested 6 months, certainly we'll do that as a look, but the board can at the year interval decide whether it is worth the work stream and worth the amount of work, or whether that we close them down or amalgamate or so on and so forth. Sorry, Deb, did you want to come in?
Yeah, I suppose it's just hopefully to help in this point of clarity, given that the IDG took overall responsibility of overseeing the health and wellbeing plan on behalf of Health and Wellbeing Board. If we trial out these 2 additional subgroups and recognising that the children's subgroup was actually being pulled in 2 directions, and that we take responsibility for those elements of the health and wellbeing plan in those subgroups, it should avoid a lot of the duplication of people that needing to go to more than one meeting. So maybe what we should do is get the membership, the 4 memberships together and in terms of reference, and just have a quick check, see how we can separate those out. And I think hopefully we should be able to match both elements then.
Yeah, we'll leave that with the kind of leads of the subgroups to kind of have a look at that. Just for a housekeeping, Dawn's comment earlier, I noticed there are some names on the other terms of reference. So if we could amend before we put them in the minutes, if we could have a note to just amend those to job descriptions only. Thank you. And Dawn wants to come back. Sorry.
I don't want to come back.
Oh.
I'm just taking my leave, unfortunately, so I need to go into an upstairs.
No, thank you, but
Apologies.
that,
Thank you this afternoon.
can you nod at the time though, and I'll get my little gold star because I've done very well. So we just need to formalise. We need to approve the Staying Healthy Partnership to become a subgroup of the Rutland Health and Wellbeing Board to facilitate action on primary prevention, wider determinants of health and health inequalities, and we're going to approve their terms of reference subject to the identifying people coming off it, and as set out in Appendix A. I will propose that. Can I have a second? Thank you, Deb, and all those in favour. Thank you, everyone. Sorry, have I done that right? Oh, that's no, good. Then we're just going to go to our forward plan and our work plan, which we did say earlier was looking a bit empty on March. I said I'd fill it up. I didn't realise I'd fill it up by the time the meeting had finished. So the things we've got to add on, Dr. James Burden has resigned from his role in as the place. What was his technical? He had lots of.
He was the clinical place lead for Rutland.
And so he has resigned that position. However, it's my understanding they're advertising for a new to refill that post. Am I correct?
Yeah, they're just looking at based on Dr. Burden's feedback around the role. They're just looking at the remit, and then that will go back out to advert.
Thank you very much. So I suggest we postpone vice chair until the March meeting, when we'll be a bit clearer about that role and so on. So we'll have the vice chair nomination on that. We've got the, now, am I right in thinking the primary care strategic review is delayed? It is, isn't it? So that could bump off.
Yeah, but we can add the dental one.
That's what I was coming to that, yeah, no. So we'll remove the primary care strategic review. Do we have any, and I know it might be, how long's the piece of string? Do we have any idea how long that has been postponed till?
We should be able to report back at whenever it is, John.
I don't think we have at the moment, to be honest, because it's a national programme, so they're looking for new partners to do part of the work. But I'll check out with the team and let you know.
Thanks, Sarah. And then maybe if we could just put a note to ourselves as an action to, I don't want to bump it off entirely. It would be good for us to have some idea. So maybe if we could relook at that in March on the forward plan of when we might be able to slot it in, if that gives you enough time to maybe have a look. That would be fantastic. So we have got, I'm pleased to say, the Rutland Memorial Hospital feasibility study. As David reiterated, that's not a feasibility study on the survival of RMH. That is for future services on Rutland Memorial, and we need to be really, really clear of that. I am really pleased that Rutland Ward will be reopening in February. That is fantastic news, and well done to the team at LPT for having that work done. I know you've had some difficulties in finding the beloved asbestos, so a thank you to the team for getting that work done as quickly as they can. According to this, Mike, I've got your annual report here. I don't know whether that might be coming up or whether that one's bumping a bit.
No, I think you stand a chance. I mean, to be fair, it might look remarkably like some of the content that was presented earlier on, but you know, we'll see.
Excellent. So we're holding you to that in March. Then we will also have are we happy for the dental? I think that's a good idea. Are we happy that we ask our NHS England partners to come and give us a presentation on dentistry? Yep, so we'll put them on.
I will contact NHS England and see if they are available for the 21st of March. I know they are very, very busy.
Thank you.
Can use the same presentation and the slide deck that they presented to us actually.
Yeah,
I think that might have been when I was on leave actually in October. So I don't think it would have changed much since then. Did you see that, Deb?
I did, and I was at the HOSC when it was discussed. So I think the report can be used. All they need to do is just update their progress on actions.
And that would be 6 months into their delivery plan, and so I think it would be timely. Yeah, we'll ask them. We'll write them a nice letter. So, and what else did I say that we were putting on here? Did I add something else on earlier? Was that it? Is that what? Oh, Deb's going to add something on.
Wasn't it the partnership?
It is getting to me. Sarah, I've got the name of it. Strategy.
Oh, goodness me, the forward plan. See, there is something. To everyone listening in, you cannot appreciate just how warm it is in here. It's got hotter and hotter and hotter, and that's our excuses even with the windows open. Yes. The forward plan that I see, it's the ICP forward, 5-year forward plan. Integrated Care Board. Yeah, 5-year forward plan. If we can put that down, we will work with you, Sarah. I'm conscious that that's the last date before we go into PERDA. Yeah. Yeah, it might be that the covering report is published and that we have to wait for the actual, I think it's very important that the board and that we maybe will work around some of the strict governance if we can, just because it's really important.
I think the other thing that we just may just want to plan as well now is if it's going to come back before the end of June, is there an opportunity for it to? But we don't need to discuss that today. We can discuss that outside.
Yeah, no, we can, and I had thought that so we're due annual council, I'm going to say the 13th of May, I'm probably wrong. It's that second Monday in May.
It's been moved to the 27th of May.
Okay, the 27th of May. That gives the timetable of meetings. Normally, and Jane will correct me if I'm wrong again, the first meeting of Health and Wellbeing Board in a cycle is around July time.
I have been pulling together draft dates, and at the moment it is currently provisionally, she says, bear with me. Provisionally booked for Tuesday, the 4th of July.
Right, so that's over. So what we might have to do, and I think it's something, if we can discuss more in March, I think it might be that we have to pencil in a special meeting in earlier in June, which I know will be a nightmare because it will be straight after, but I think it might be that we have to do that, have a standalone special meeting just for the 5-year plan. But I think we'll discuss that in March when we're a little bit clearer on where we are with it and things, if that's okay. And so that's that. So does anyone else have anything else to add on the work plan, annual work plan? No. Is there any other urgent business? No. I have one little bit. My old mucker sitting there at the end smiling at me. Mr. John Morley is getting his pipe and slippers. We think before the end of the next meeting. I don't know if you're going to be here for the March meeting.
My last day is the 22nd at Rutland County Council. The next meeting's on the 21st, so probably not, because I'll be hopefully clearing my desk.
Yes, so I would like to publicly thank him for everything he's done for Rutland. It's going to be really, really difficult. I don't know, as portfolio holder, it's really tricky to think that my old mucker's not going to be here to keep me in order. I would like to, from a Health and Wellbeing Board perspective, really thank you. The work we've done is, I've been a member of the board on and off for 4 years, and it's phenomenal, I think, and a lot of that is through your drive. I don't know whether anyone else will add. Clearly you'll still be here on the 21st, so we might drag you in anyway, but from the chair, thank you. And that's it. Oh, Deb, do you want to come in?
Just going to say, if you actually turned up to the meeting, you might get a gift.
Sold.
So as we've just said, the next meeting will be on Tuesday, the 21st of March at 2 o'clock. I would like to point out it is 16:28 and I declare the meeting closed. Thank you.